Stube.
Thank you, Mr. Chairman. Nonprofit hospitals derive substantial benefits from their tax-exempt status, but in some cases aren't providing the charity care that their nonprofit status requires. Nonprofit hospitals have an obligation to serve indigent patients and not try to push them off on other hospitals, but the numbers show they aren't doing this. For instance, in 2020, nonprofit hospitals received almost 40% more in tax benefits than they provided in charity care. A New York Times report found that a nonprofit hospital in New York City received nearly $250 million in tax benefits a year, for which they are supposed to provide charity care. But according to the report, that hospital routinely told ambulance workers to take homeless patients to other hospitals. My question is for Dr. Bai and Dr. Levinston. There are several requirements that tax-exempt hospitals must meet to maintain tax exemption, two of which include maintaining a written financial assistance policy for needy patients and the requirement that hospitals set billing and collection limits. But we are increasingly hearing about how some nonprofit hospitals are making it difficult for eligible patients to get financial assistance, are delaying checking patients' eligibility for financial assistance, and are sometimes engaging in aggressive billing and debt collection practices. Are you familiar with these practices? And if so, can you elaborate on the practices you have seen from some hospitals? I'll start with Dr. Bai.
Thank you, Representative Stube. Thank you very much for the question. What we have seen is that hospitals have 100% discretion in designing those eligibility criteria, right? To start with, if you have your resource available, you can make the policy very generous. So many people would have been qualified to receive charity care. That's number one. But what we are seeing is no, many hospitals did not do that. And beyond that, as you already mentioned, they are trying to make the charity care policy very obscure. So patients under stress would not be able to find the policy, so they would lose the opportunity to apply for it. And then after that, once they incur that, some hospitals go into very aggressive techniques to go after them, garnish wages, etc. So these, as you mentioned, this is really against their charitable mission, not consistent with what's the purported mission statement.
Dr. Levinson, you have anything to add to that?
I agree with everything Dr. Bai said. I should also mention there, again, is a requirement that hospitals have a financial assistance policy in place. As Dr. Bai was mentioning, there are fairly limited requirements of what that financial assistance policy has to entail, and that both includes who's eligible for charity care, but also it grants hospitals substantial flexibility in their application procedures and how often they have to notify patients of their eligibility. So for example, hospitals are currently required to make a reasonable effort to determine eligibility before taking extraordinary collections actions. However, that could, for example, include notifying a patient of their eligibility and giving them 4 months to apply for financial assistance. There are some areas of the country where states have required more transparency around financial assistance policies, such as sending patients information about financial assistance with every bill that they receive and once their bill goes to collections.
And I'll just stick with you, Dr. Levinston, if that's okay. When nonprofit hospitals aren't providing the charity care that they are obligated to provide, how does that impact other hospitals that are in the area? Dr. Levinson first, and then you can add if you want.
Thank you for that question. So, in theory, it most directly impacts the patients at those hospitals who ultimately might be saddled with medical debt. It could also, I think, conceivably lead to some patients choosing to receive their care at other hospitals where those hospitals will in turn be obligated to cover their charity care costs.
Dr. Bai, you want to add something to that?
Thank you. And more importantly, these patients are not high-income patients, right? Many of them are struggling working-class Americans, very marginalized. And if they are being collected, very aggressively pursued for the medical debt, they might just give up and fall into the welfare trap. That will increase taxpayer burden. See, there is a social contract. So the taxpayers let the subsidy go to nonprofit hospitals, but in return, they must help taxpayers by helping those marginalized and very struggling low-income Americans so they can stay in the workforce and stop being a taxpayer's burden. So I think that is the breach of the social contract.
Well, and real quick, I only have a couple seconds left. And for both of you, of the various types of community benefits that hospitals provide, how many of those do hospitals receive reimbursement for through other means such as Medicare, Medicaid, DSH, 340B, et cetera. So they're taking that as well, correct? Go, Dr. Bai.
Thank you. So right now, there's no transparency regarding the 340B program. So it has become a buy low, sell high program. So that is the transparency we probably need. But in the DSH also is a black box. The tax exemption value also, as we have mentioned, you don't have the information at the hospital level. Thank you.
I'd ask unanimous consent, Mr. Chairman, to add, hospitals often don't help needy patients, even those who qualify. Ask unanimous consent to add that to the record, and also the New York Times article, they were entitled to free care, hospitals hounded them to pay.
So ordered.